Hello, it's my absolute pleasure to be here with you for this pre-conference workshop introducing some of the concepts of the Ola Grimsby Institute. I've been involved in the Institute since meeting Ola in some courses in 1995 and been through the training, residency, fellowship, and instructing since 2000. It's been an incredible growth in my clinical practice, and I hope you can experience some of the excitement of really taking your practice to another level. And we're excited about the possibility of bringing some of this thought process to Pakistan and share it with you all in our humble way to try to improve the physical therapy practice there. This workshop will be a clinical presentation of our thought process and some of our techniques. What we're going to do is talk a little bit today about the examination process and clinical decision making, and then show some techniques that are relevant to the case study that I'll be presenting, and finally some exercise concepts as well, so you can get a taste of the full breadth of what we do at the Ola Grimsby Institute. It's a broad conceptual approach, and to share it in 3 hours is challenging, but it's not the first time that I've been challenged by Ola to present something. It's always a pleasure to meet and work with therapists from around the world, and I sincerely hope that one day I'll be able to meet you all in person once this current situation is safer to travel and be in person. So I need to start by thanking Ola Grimsby just for helping me in my clinical journey. This is a photo I took of him in, I think, 2008. I was assisting him teaching in Parma, and his incredible energy and vision and really commitment to the profession and the sort of perfection of the practice is truly inspiring, and it's led to the growth of the Institute, and we have residencies and fellowship programs throughout the United States, and as you can see on this slide, in many countries around the world. It's really just his, like I said, passion for excellence that's kind of motivated many instructors like me to get involved, and I hope you have the pleasure of meeting him someday as well. So the workshop outline is presented here, and the first thing I want to talk about is sort of the general philosophy of what does manual therapy really mean in terms of the OGI. And I selected this statue by Rodin, The Thinking Man, because really it's a very thoughtful approach to clinical practice and optimizing outcomes. Manual therapy, to me, and that's because of my training, doesn't mean a technique. It means a profession. It means an autonomous way of approaching patient care with a deep understanding of a comprehensive view of the patient, including radiology, nutrition, psychology, and that to me is manual therapy. And an important part of that is the clinical decision-making part. And I think this comes from Ola and his experience in Norway, where in that country, it is in fact a different credential than physical therapy. When you have the advanced training, you're recognized in a different way, and you're billing with different codes, and it really is sort of another level of practice, and that's the way I think of it. And I'm grateful that, you know, I get to struggle and work in a clinic every day working with patients, and because of that, I stay incredibly humble. I I understand a lot about the body and physical therapy, but nevertheless, I struggle in this clinic, in my little room, because that's what this is all about. It's working with humans, and there's, you know, if anyone tells you they have all the answers, it's because they're not seeing patients anymore. And so to me, that's my ultimate credential, is that I'm working with patients every day. So what we're looking for in our clinical examination is, as much as possible, to determine the tissue and lesion. What tissue is it that we're trying to apply biomechanical energy to make cellular changes to optimize function for that patient? Obviously, it's usually more complicated than that, and it's not just one type of cell that we're targeting, and there's a whole psychology involved, but that is the goal for what we're doing. And so today we're going to go through some clinical decision making, looking at a lumbar spine example, understanding that even though our goal is determining what tissue is in lesion, there are several overlapping models of pathology that we have to take into account. If all we do is think about biomechanics, we're going to get lost, right? It's not as simple as just finding out what joint is stiff and what joint is loose and going from there. The biopsychosocial aspects are huge. The biochemical aspects can't be discounted, and the neurophysiological part is probably the biggest part of what we're doing in terms of our techniques and even the language we use in terms of talking to our patients. In the last 15 years, I feel like every manual therapy conference I've been to has focused on the biopsychosocial approach to treating pain. This is some amazing research using a functional MRI and showing how different parts of the brain respond to expectations and identifying the effect of placebo and nocebo. This is a really important part of patient care, but it's not really new. Hippocrates talked about the effects of emotion on disease, and I think any successful practitioner throughout the history of time has used this to their benefit in terms of helping patients get better. It's been, I think, described in a very useful, succinct way by some leaders in our community, physical therapy, but it doesn't mean that everything is just psychology. There's always a mix, and that's where the overlapping models come into play. And so if you're really good at one, you're going to be a good practitioner. If you understand all of them and how they have overplay, you're going to be better. And that's what this is all about. That's the fun of really trying to be excellent here. So this is our flow of procedures, and it's probably not unlike what a lot of you have used in the past. And we're going to basically go through this flow with our model, starting with the initial observation, which is basically how is your patient sitting in the waiting room? How are they standing when they're filling out the paperwork? What's their posture like, and what's their energy like when they shake your hand and you say hello? That's the initial observation. And if you think about it as a practitioner, how much information you're digesting in that moment. You know, when you watch them walk into the room, or you watch how they're communicating with your front desk, there's a huge amount of information. Your computer's already running full speed. The next thing we'll do is go into the history and interview. And with that, what we're going to do is bring our model out. If you could come over here, I'm still sharing screen. So basically, I have with us today, this is Kara Mathis. She works with me, so she's a physical therapist, and she's highly trained, working on her fellowship status. And I'm going to kind of use her as an example of a patient. And so let's walk over this way so there's a little more room. And what if your patient comes in and go ahead and turn around, and tells you this is where it hurts. Okay? That's what they tell you. This is where it hurts. So you would take your history, right? Which is aggravating factors, easing factors, how long has it been going on, what postures aggravate it, is there any correlation with any physical activities that you do or stress? Has anything changed in your life recently in terms of both biomechanical factors, emotional factors, nutritional factors, sleep, everything that you can learn about her, obviously, as well as looking for red flags or other contributing factors, ruling out things like ankylosing spondylitis. I was talking about differential diagnosis. If your patient comes in and points to the Fortin area or the SI joint region, what could possibly be causing pain? You should be able to, in your head, imagine multiple things that could be leading to pain in that area, right? It could be a disc in the area, it could be a facet, L5S1, it could be a ligament injury, it could be a muscle, it could be a trigger point, it could be a referral from some other part of the spine. You want to have your mind as open as possible at that point and not jump to conclusions. And that's why with our residency training, the focus is on what we call hypothetico-deductive reasoning, which is really an exhaustive approach at ruling out different tissues that could potentially be causing the problem. And not thinking, oh, she pointed there, it must be her SI joint, or that's the muscle that's strained. Your job when you start your examination is to rule out tissue. And so in order to do that, we have a process using a diagnostic pyramid. And this is something that is a little intimidating when you first look at it. But I can pull it up here and kind of walk you through it. All right, so this is Kara saying it hurts here. This is where my pain is. But this is a diagnostic pyramid, and hopefully you can blow this up somehow and see the details. But what you have across the top in this column here is all the tissue that could potentially be causing pain in that area, from skin, subcutaneous, ligament, fascia, joint capsule, bursa, etc. And you have basically our flow of procedures on this column on the left, starting at the bottom with initial examination, history, structural inspection, active movements, etc. And as you move through that flow of procedures and you get to different aspects of your examination, you're able to rule out these different tissues. And it's called the pyramid because ideally, as you approach the top of the pyramid, you're narrowing what tissue is in lesion. So you've ruled out skin, you've ruled out ligament, and now you're sort of honing in on what the actual tissue is and how you're going to address it. Okay, so that's the goal of our treatment approach. And now I'm going to walk you through a little bit of it. And Kara, if I can have you turn and face away from us, we're just going to start with an initial inspection. And so what I'm going to have Kara do is just stand habitually and take a look at her sort of from a global standpoint. So where is she in this sagittal plane? Are her shoulders deviated one way or the other? So starting globally, is her head on top of her shoulders? And then we can start to look a little more detailed, starting at each kind of anatomical landmark, starting with her calcaneus, looking to see if her Achilles tendons are vertical, looking at the bulk of her calf or popliteal crease, the bulk of her hamstring, bulk of her glutes, ischial tuberosity, greater tubercles, iliac crest, and then we're going to want to see her spine. And so I'm going to ask her you mind tucking that up just so we can see this part of her spine, right? She pointed to here as being her pain. And so now we're doing a little bit of a more local inspection of this area, looking for any metabolism changes, changes in the skin integrity, changes in any sort of like hair thickness or coarseness, any autonomic changes that we might see in this area. And then of course we're going to look at her spine in terms of scoliosis, any kind of rib humping, scapular position, height of her shoulder, and then again her neck. Normally I would have her stand in this one place and I would walk around her, so not to disturb her center of gravity, but for this purpose I'm going to have her turn 90 degrees to the right with her feet. And now we're going to look at her from the side view. So here again, we're going to start globally, all right? Big picture, okay? Starting at the feet, looking up just to see where is her trunk on her body. Is she posterior, leaning back, causing some extension in the lumbar spine? Is her lumbar spine flat, trying to avoid facet compression or stenosis? And then we're going to get a little more detailed, looking at the position of her ankles, looking at her knees in terms of flexion or hyperextension, hips to see if they're flexed and if she's anterior tilted or posterior tilted, looking at the curve of her lumbar spine, the curve of her thoracic spine, position of her shoulder in relation to mastoid process and head, and anything that might give us a clue in terms of contributing to her issue. And then go ahead and turn and face the camera. And then we're going to basically go through the same thing from the front view. So we look at her in three planes, from behind, the side, and front. In the front, again, starting globally, looking at head on shoulder, shoulder on trunk, anything off in terms of weight bearing. And then we're going to look more detailed, arch height, hallux valgus, tibial position, if there's verum or valgum, genuverum or valgum. You could palpate some landmarks in terms of like ASIS, right? Looking for symmetry, especially because she pointed to her SI joint. Iliac crest height, as she's just relaxed, you can kind of look at her waist angle to see if there's one that's bigger than the other. Looking at her sternum and manubrium, clavicles to see if there's any asymmetry in terms of anterior, posterior, up or down. All right, so this is general inspection, looking for any kind of asymmetries that might clue you in. Before we move to active range of motion, we are going to do a little bit of just quick functional tests. And so I'm going to ask Kara to just stand on one leg and balance. Perfect. And so what we're looking for here is what she does with her center of gravity, right? If she has a weakness in her left hip in this case, she would probably lean to that side to decrease the demand on that gluteus medius. Obviously asking if this increases pain. We can switch to the other side just to see if there's any shift or asymmetry. Okay, at this point I might have her do a little bit of gait. Just walk over to that weight stack and back. Okay, looking for any clues in terms of decreased stance time on one side or pain, obviously with weight bearing or anything along those lines. All right, so starting with active range of motion, again we're going to look from a couple different directions, especially with flexion. So I'll just have her stay where she is, but I'm going to start from the back and ask her to just keeping her knees straight, bend forward like you're going to reach toward the floor, okay? And so I'm going to start from the back so that I can get a good view of her ribs and thoracic spine to pick up any kind of scoliosis. Come on back up. I'm going to look to see if she has any deviation, right or left, that might imply that there's a pain or a hypomobility somewhere. And obviously we're going to look for pain, and we're going to look for apprehension of movement. Willingness to move is really important. Now, to get a better look at any deviations, I'm going to have her repeat that with her eyes closed. So I'm going to ask her to close her eyes, do the exact same thing. Now, since she doesn't have the visual cues to correct her, we're going to see how she does. Come on back up and see if that deviation may be increased with the visual cue eliminated. And then finally, I want her to do it one more time, and I'm going to look from the side. Go ahead, Kara. So now I'm looking at the reverse of her lordosis, the smoothness of her curve, looking for any hinges or any parts that aren't moving normally, and come on back up. All right, so that's active motion, looking for willingness, pain, obviously range of motion in general. Go ahead and turn and face away from the camera so we can see your back. Perfect. I'll move this up a little bit so I'm not headless the whole time. All right. So now we're going to look at a couple other planes, and we're going to start with just straight side bending. So I'm just going to tell her to just slide her finger down the side of her leg, and I'm just looking at her curve here. All right. And she pointed to pain on the left, and so we want to see if there's any hinges and what this curve looks like. Okay, and go ahead, back up. It looks pretty smooth. Going to the right. It's actually a little bit straighter here. Okay, and a little bit of a hinge right in this area. Not sure if you can see the details, but this is, come on, back up. This is a good place to look for changes in mobility. Now that doesn't diagnose her as having a hypomobility. It could be a lot of things. It could be a motor control issue. It could be just a habitual thing, but it's something to note. She has decreased mobility, bending to the right, which could mean that these facet joints aren't opening as well. All right. Or they could maybe not be closing as well on this side. Either way, there's a smoother side bend to the left with her. Go ahead and cross your arms. And now we're just going to do straight rotation. So go ahead and rotate as far as you can. She's going to the left. And what we're going to see is the side bend that comes along with rotation. You can't really see the vertebrae rotate, but you can see the side bend that comes with it. So she rotated to the left. You can see a little bit of right side bending there. Go ahead to the right. And we're looking to see any side bending, again, that occurs with that. And you can go back to the center. And so again, we're looking for willingness to move, pain, reproduction, overall range of motion, all those things in terms of active range of motion, and we're gonna document it. And in this case, with this case study, what happened was when she bent to the right, she complained of tightness on the left here. All right, and actually that doesn't bend as well. So she has some tightness up here in her thoracolumbar region or her upper lumbar spine. When she side bent to the left, it was actually a little bit uncomfortable. It was a little bit uncomfortable on this left side. Okay, and when she, come on back up, and when she rotated to the left, it also felt a little tighter here. A little tighter here. So there's a couple things that are happening that are implying the facet joint capsules aren't liking to open up on the left side. Could be muscles, but those things both go with facet joint opening. And if you don't remember the biomechanics of that, in the lumbar spine, see if I can show you on this camera. All right, so if we're looking at what we just did, like say Kara rotated to the left, okay? If you watch this facet joint, where my finger is, okay, and I rotate to the left, you can see that it gaps. All right, when I rotate to the right, it compresses on the left. When I turn to the left, it gaps. Okay, obviously, when you side bend to the right, all these facets have to open, and she wasn't really doing that. She was kind of straight through there. Okay, so this is not a diagnosis right now, but it's a suggestion and something that we're going to put in our computer as we're moving through this. Now, I want to know if she has the same pattern with passive motion as she does with active motion. because one is using contractile elements, one is not. And this sort of comes from Cyriac's contribution, looking at passive and active range of motion. So I'm going to put her kind of high sitting here, Kara, so kind of right here. That way you'll be able to see me from some different sides. Go ahead and sit. Let me see where you ended up. Not too shabby. You go down this way so we can see her. So this high sitting position is good because it keeps her lumbar spine fairly neutral. If she's sitting too low, she's going to have flexion through there, and it's going to change her mobility because of the ligamentous tension. All right, so I'm going to have her just cross her arms, okay? And I'm going to just move her through the same motions that she did actively. So the first one we're going to do is flexion, so I have to support her and just let her sort of slump and try to kind of roll her back onto her sacrum to do a little bit of flexion with a little bit of overpressure, okay? And see how that feels, all right? Does it cause pain? She said there's a little tightness on the left, nothing really sharp, not that different than the active. All right, for extension, go ahead and put your fingers behind your neck, elbows together. Now I want to support her and balance her because this is passive, right? And so if I just bend her backwards, she's going to be off balance and her abs are going to be working. And so I need to kind of shift her forward, counterbalance her, and take her into extension of her lumbar spine. Come on back up. She made a little squeaky noise. But that was end range, right? And we're going to interpret that in terms of how she felt. It may or may not be different than active because frequently you can go farther into passive movements, okay? So for rotation, I'm just going to rotate her toward me, nice control, and just take her to the end range, full end range, okay? And then I'll do the same thing going the other direction. Just nice control. Got a little tiny thigh contact here so she can feel the stability. End range. See if she has that same tightness that she complained of. All right, if she had it with active motion and with passive motion, that implies that it's a non-contractile thing because it's not a contractile activity right now. So it's a passive structure, facet joint potentially. All right, so looking at side bending, I'm going to come underneath her and create some from below. So here, my shoulder's kind of underneath her shoulder. I'm going to bring her this way and bend her to the right. Okay, and then let her come back down. All right, take her to the end of the range. You want to see how that compares to when she did it actively. So I'm under her iliac crest, ischial tuberosity. I'm going to roll her toward me and bend her to the left. See how that compares to when she was standing. Okay, so active range of motion, now passive range of motion. Okay, I want to do a little bit of resisted testing to see if that produces any kind of pain. So let's have you come here, and we're just going to start in neutral. All right, actually, let's have the elbows or fingers back here again. It's a little easier. So just in neutral, I'm just going to resist flexion. So don't let me move you, and I'm going to bring her, I'm pushing her into extension and then relax. I'm going to have her slump into a shortened position of flexion. Don't let me move you. I'm going to try to move her into extension, relax. Then I'm going to bring her into a little bit of extension. This is outer range. Don't let me move you farther into extension. Okay, so here, go ahead and relax. In the lumbar spine, usually there's not a contractile element of pain, but sometimes you can get symptoms related to the multifidus attaching to the joint capsule or the meniscoid in the joint capsule. So I would do this for all planes of motion. I'll show one more, just rotation. Go ahead and cross here. So I'm going to be testing left rotation. So I'm here, I got good control, and I'm going to say, don't let me move you. I'm pulling her toward me, so she's doing left rotation, okay? Now we're going to put her in a shortened range of left rotation. Don't let me move you. Good. And relax. Outer range of left rotation. Don't let me move you. And relax. Okay? So relax your arms. So I don't need to show all planes, but that would be part of our procedure. Active, passive, and resisted in 3 positions. And that's really important when you're looking at a tendinitis or something of that nature that has a contractile component and you're trying to rule it out compared to a ligament or something along those lines. All right. Next thing we're going to do is palpation. And we can use this table since it's here. So let me just bring it over. I'll bring it a little closer so we can look down on Kara. Let me see 1 second how it looks. Yeah, I think for orientation I'm going to spin it. That'll work better. And then I'm just going to drop this so you can see better. See my one face here. Yep. Okay. Let's see if I bring this a little closer. If we can see down on the spine. This will go from the side and see how it goes. Yeah, not too shabby. All right. Okay, so first thing is before we get in here and start mucking around with palpation, we want to get a good sense of the autonomic status of her spine. And so there's a test that we use consistently called the scratch test. And what we're looking for is a histamine response depending on what's going on autonomically. If there's a joint that's hypomobile, sometimes it won't react as much. If it's an irritable segment, sometimes it will react more. And so what I'm going to do, Kara, is I'm going to take my thumbnails and I'm going to sort of scratch them down your spine the long way, and then we can start our palpation, and then we'll kind of see how it reacts. And I want to get into the area that's uncomfortable, so I'm going to go to here, and now my thumbnails are on her paraspinals, and I'm just going to drag down. Doesn't feel great, but it's not too deep. And you can see that initially when I do that, it turns red, and then, white. And that's the sympathetic reaction to that little micro trauma. And then immediately it turns red. And she's already got 2 nice red stripes. I'll give you a peek at that. It's actually a little bit less red on the left. And that's where she was a little more hypomobile. I don't know if you guys can appreciate that, but right kind of in this area is not as red as here. Okay? See where we are. So as that's kind of evolving, we can start with our subcutaneous palpation. And so we're just going to look for mobility in the skin, looking for any kind of atrophic changes, any sweating, any hair change, any orange peel phenomena when you pinch it and it kind of puckers like an orange peel. Also looking for areas of sensitivity. Especially with pain in this area along the iliac crest, because the cluneal nerves from the first 2 lumbar vertebrae, superior cluneal nerve comes right down into here, and there is a syndrome or phenomena where you can get referral from this part, the upper part of the lumbar spine, lower thoracic, into the iliac crest. So we want to see if there's sensitivity in the skin here, how it feels compared to this side, and in this case, this is just a little sensitive on her, all right? Her subcutaneous tissue is just a little bit irritable on the left compared to the right, okay? From there, we can get more detailed and deeper. starting right next to the spine with the lumbar multifidus, looking for pain or trigger point or referral. All right, so we can go all the way down to S1, looking at the lumbar multifidus. Okay, and then we've got iliocostalis, longissimus, and semispinalis. Sorry, that's from lateral to medial. Iliocostalis, longissimus, spinalis. So starting with the erectors and the spinalis, and just looking for anything unusual in terms of tenderness or muscle guarding. All right, I would take that right down through there. We'll do it on the left. Carefully looking for any trigger points or thickening over the facet joint. And there's, let's say, a little bit of a trigger point here and maybe some thickening of the facet joint as we palpate through there. Okay, we would take this palpation down along the iliac crest into the SI joint itself to see if it's tender right at the SI joint on both sides. The sacrum as well, the muscles in the gluteal area, hips, ischial tuberosity, basically palpating all subcutaneous muscular ligamentous tissue that we can to see how that's contributing to her pathology. And in this case, we found a little skin sensitivity, some trigger point here in this area, and a little bit of thickening in the facet on the left side. Okay. I'd love to ask you if there's any questions, but sorry, next time we'll be able to do that. Okay. All right, next thing we're going to do is a quick neuro screen. So let's have you come off of there. And I'm going to spin this back over to here. And I think I'll just have this again. Back this up a bit. Okay, have a seat right there. There's our subject. Great. So, neuro screen's important, and you can get this done in 3 or 4 minutes once you get proficient at it. Let's pull up here. Thanks. Okay, so just quickly, we're going to look at her deep tendon reflexes. We're going to do patella. We're going to do repeated testing to see if there's any change, any fatigability, or any ramping up of her DTR, because that could potentially imply some central contribution. All right, so that's L3, L4, 5, medial hamstring. So I just have my finger on the tendon. This is not present in everyone, and it's not jumping out too much on Kara, so I'll compare to the other side. And then for Achilles, I'm just passively dorsiflexor. And again, we're going to do some repeated to see if there's any change. Okay, we'll do that on this side, repeated on this side. Light touch. L1 would be the inguinal area, L2 would be right below it. We're going to start here at L3, which is the VMO, basically, and we're just going to have her look forward so she's not getting a visual cue, and ask her, is there any difference between how this feels between the right and left? She says no. We're going to go to L4, which is the biggest overlap is at the medial malleolus. L5 would be the first dorsal web space. Any difference between right and left? That was L5. S1 would be the kind of the soleus and also the lateral side of the foot. Any difference between right and left? S2 is a little bit higher. Okay, so we're going to do light touch, but we're also going to do sharp touch because they are traveling through different pathways, and depending on what's going on with her, she may or may not have a change in one or the other. And if she has an irritated nerve root, for example, the light touch may be hypersensitive, but the pinwheel could be normal. If she had a compressed nerve root, it would be significantly diminished with the pinwheel or the sharp, and so it can help you determine the state of the nerve, which is really the most important thing about your neurological testing, to see if it's compressed or if it's just irritated. So with this pinwheel, again, we're going to do the same exact thing, just asking her, just trying to use the weight of the wheel to see if there's any difference between the right and left, going through those same cutaneous patterns, looking for any changes. Okay, so 3 quick things we're going to do with our neuro screen. We did 2 of them: deep tendon reflexes, cutaneous innervation, and the last is motor. We're going to start at L2 with hip flexion. So she's going to hold like that, and I'm just going to tell her, don't let me move you. And I'm going to give her resistance and relax, see if she has any pain, see if she has any weakness in her hip flexor. I'll compare to this side. Okay, L3 would be quad. Don't let me move you. There's a lot of overlap in the quad, but L3 works. Good, and relax. L4, hamstring, don't let me move you. Good. None of this means anything unless you compare it to the other side. Just for time's sake, I'm cruising through here. L5 is dorsiflexion of the feet. Don't let me move you. Good. You can do the big toes simultaneously. That's L5. S1 would be perineals. Don't let me move you. So I'm trying to twist her. Or you could have her do single leg heel raises for S1. Okay, so quick neuro screen. With this case study, nothing came through as positive. So her nerves are basically intact in terms of compression, irritation, and from that point of view. Okay. All right, so we're working our way through, trying to rule out different tissue. We'll sort of go back to the pyramid and revisit that once we get a little more data. But all this is going into our computer data bank to figure out exactly what tissue it is that we're working with. All right, so after neurological tests, we're going to go to special tests. And for special tests, you want to think about this from a tissue standpoint. And what tissue are we trying to rule out, right? So we listed off a few. Disc. What tests do we have? What special tests do we have to rule out a disc? We got a couple. One is a heel drop test. Go ahead and stand up. And I'm going to ask Kara to just raise up on her toes and then thump down on her heels. Good. And let's do bilateral at first. So just thump down. Okay. And so that impact, axial load, if there's kind of a hot aggravated disc, could be positive. Other test is the lumbar shear test. So let me, I'm going to bring the table over. So just give me 1 second. So let's have you on your side facing me. Just turn the camera. All right. So the lumbar shear test has been studied for validity, and it's decent. It's better with practice. And what we're going to do is we're going to create a shear kind of in the plane of the disc through the femurs. All right, can you slide toward me just a touch? All right, so we want to have her lumbar spine in neutral, so I don't want to flex her too much, but I want to know where I am. So right now I have my middle finger in the inner space between L5 and S1, and I can feel the motion there, and so I'm going to neutralize it. Now I'm going to, with my hip, I'm going to move through her femurs, kind of in an axial load through her femurs to see if there's any bit of shear between L5 and S1. And then I'm going to go up between L4-5 and add that same shear. And Kara's pretty flexible, and so I'm feeling a tiny little bit of wiggle, but it's the same at each level. So I don't feel any excessive shear, and that's going to happen if she has, mostly if she has a degenerative disc that's a little bit lower. There'll be a little more play in that segment. It could be positive also with a disc herniation, but it was negative. Okay, so the tests that we have for the disc are negative. What other tissues do we want to rule out? Okay, thinking about neural irritation, let's have you roll onto your back, and we can look at a whole combination of neural tension tests, starting with just passive straight leg raise, asking her how she feels, taking her up to the point of any kind of discomfort. If she feels, oh, that's kind of the end of my range, does it reproduce your pain? No, just hamstring stretch. Okay, we're going to add some active dorsiflexion. Obviously, she's going to get more stretch throughout, but is there anything specific in that SI joint region? All right, not at this time. We're going to do the same on the other side to compare. The most reliable neural tension test that we have and most specific is Cram's test. And so we're going to use that one same way. I'm going to bring her up until she has tightness. Okay, could be pain, could be tightness. I'm going to add a tiny bit of knee flexion, 5 or 10 degrees. Keeping the knee the same, I'm going to flex her hip till she's tight again. All right, and then I'm going to just add a tiniest bit of knee flexion, and then with my thumb, I'm going to press into her popliteal fossa, which is sort of direct pressure on the sciatic nerve to see if she has any sensation or reproduction of symptoms anywhere. Okay, that would be for sciatic nerve irritation, but mainly I'm curious to know if it reproduces her pain, right? The well leg raise, which is, in my experience, very indicative of a big nasty disc herniation, and that would be somebody who has their pain on the left, you do straight leg raise, and they have pain at 10, 20 degrees. This is pretty dramatic. And then on the opposite side, the well leg, it's usually higher, but also pain on the left, very limited, you know, like 40 degrees. My clinical experience, which counts as evidence-based medicine, by the way, that's indicative of a pretty big disc herniation, well leg raise. But obviously she doesn't have that in this case. Quickly, other neural tension tests, it's a little less specific, but very sensitive, is a slump test once you sit facing that way. Raise this up a bit. And I prefer to do this actively just because I don't want to irritate people. More clinical experience. And so what I'm going to have her do in this position is go ahead and slump, right? Chin to chest, just like she's doing. And along the way, you're going to ask her how it feels. Any increased symptoms, any pain. And then we're going to say, go ahead and straighten your knee out. Any change, active dorsiflexion, any change, right? All of those are sensitizing maneuvers to the sciatic nerve. If she has pain here, and then she lifts her chin a couple inches and the pain diminishes, there's some kind of irritation in the sciatic nerve. Go ahead and relax. There's a lot of things being stressed with this test. It's very specific fascial tension at play here as well. So, but it is a good way to sort of prognosticate how she's going to do and give you suggestions on how to treat it from a mechanotherapy standpoint. Okay. More special tests, right? Remember, she came in and she said it hurts right here. What else could be causing pain there? Could be your facet joint, right? So how do we want to do a special test for a facet joint? Come on over here and stand facing me. Let's see if we got you in view here. Tiny bit, yeah. All right. So remember, go ahead and point to your pain again. Left side pain. So if it's a facet joint directly, right, it's going to be one of the lower ones, L4-5 or so. And so how are we going to compress that? Remember, I showed you on the spine, if we turn toward it, it gaps it. Okay, so if we turn to the right, it closes it. Closes this facet here. Now, if we want to add more compression, I'm going to ask her to lean straight toward me. So kind of back and sideways. That's a quadrant test for the facet joint. All right. So if it's her facet joint, she's not going to like that. It's going to reproduce her pain in this area. Okay. The test that looks like that, go ahead and turn and lean back, is Sperling's. If I wanted to add some compression, and in that case, you're really looking more for a radicular kind of reaction of the nerve root. Okay. There is a differentiation test here, also called Kemp's test, where you're differentiating between the facet and the disc. And so in this case, if we did the same thing, right, compress the facet here, and then if we kept this side bending and this extension, but rotated her the other way, now you're opening that facet joint. If she still has pain over here, that means it could be from the disc because she's compressing it. Go ahead and back up. So that's a standing Kemp's test. Another way to try to differentiate between the disc and the facet. All right. What other tests do we need to do to kind of rule out pain in this area? Well, we could do a lot to rule out the SI joint, right? And luckily, Mark Laslett did some really nice research looking at a suite of tests to try to provoke it. Palpation of the pelvis hasn't been found to be as reliable as a diagnostic thing for the SI joint. There's been studies by people like Stefan Blumberg who sort of showed that you could do manipulation and completely change the symptoms and the findings, but with radio-opaque markers, there's really no change in the structure of the SI joint, so it's mostly more of a neurological thing. But for stress testing, let me have you on your back again, please. All right. So the most sensitive test that Mark Laslett found for the SI joint and reproducing it is the posterior thigh thrust. Okay, so I prefer to have the table low for this. You're going to flex the hip up to about 90, adduct, maybe 10 or 15 degrees. Make sure she doesn't have a pinch in her hip. And then you're going to give pressure straight through the long axis of the femur. Okay, so I have my sternum on it, and I'm checking for pain. Okay, this is found to be the most reliable for SI joint dysfunction, and he did his study confirming it with a lidocaine injection. So if some of these tests were positive and then it went away with the injection, you know, he was pretty confident in his diagnosis. So it's a good study. He's from New Zealand, and he's a very entertaining speaker. All right, so that's one SI joint stress test. Obviously, we do the same on both sides. The other would be gapping posterior. So I'm going to be on each side of the ilium, pressing medially, looking for any pain. I'm going to do compression posterior by pushing apart. Okay. Looking for any reproduction of pain. The other test that he used was Ganslin's. Let me have you keep your head and shoulders there, but move your hips over the edge so you're kind of at an angle. And then you're going to hold on to this knee, let the other one flop off the edge, kind of like a Thomas test. And so this is creating a big anterior rotation in her left ilium. So you passively overload it, looking for pain. And then the last one is just a sacral thrust from prone. Go ahead and roll onto your belly. And you just want to get the heel of your hand right on the sacrum and just check for any reproduction of pain. So if in this case, I could go through that suite of tests and nothing reproduced the pain, I'm confident that it's not the sacroiliac joint. Okay? So that's special tests. There's more for strength and other things, but you know, you get the idea. Next thing that we're going to do, which is a really important part of the examination, is specific mobility testing. So roll on your side one more time. And it's important that Kara's spine is in neutral for this, so I'm going to just take a peek at her waist. And if she relaxes, there's a little bit of a side bend, right? You see a little bit of a side bend to the left. So I'm going to just use a towel to neutralize her. Because if she's side bent, it's going to affect the motion in another direction. So it's going to slide that in there, and that's better. Okay? So this can be done in sitting. I'm going to show it in standing. And we're basically going to be assessing the mobility between the vertebral segments. And we're going to grade them, and I'll show you the grading scale on a slide in a second. But just so you can see, I'm taking my palpation finger and putting it directly between the spinous process between L5 and S1. And I know where L5 is because it's kind of like a pencil eraser. It's a small little round spinous process. And when I extend her, it goes away from me. It kind of dives anterior. So that's where L5 is. So right here, I'm at L5 S1. Slide your hips toward me a little bit, please. A little more. So I want her greater trochanter pretty close to the edge so that I'm pretty free with her thighs. All right, and so now I'm going to do a few flexion movements. Feel the mobility of those two spinous processes separating. Then I'm going to go up another level and check there. Okay, so that's L4-5. Up one more segment. L3-4. Up one more segment. L2-3. L1-2. And I could keep going up in the thoracic spine, but you get the idea. Okay? In this position, I can do extension, which I'm going to do from the back side. So she's going to stay right there. I'm going to use her cervical ankle side, her left leg, and again, same palpation. I'm just staying out of the way of the camera. Palpating L5-S1, feeling mobility, L4-5, feeling mobility, L3-4, on up. Okay, this is a lot easier to do it from the back because you're moving her toward you. If she was a big, heavy patient, I'd have her a lot closer and my body mechanics would be much better, but I wanted you to be able to see that. All right, moving on to side bending. What we're going to do here is, again, now I'm going to palpate between the spinous process on the upside, okay, which is her left. So I'm palpating between two spinous processes on the left, and then if I just rock back, it creates side bending to the left, okay, and I can feel the mobility. So I'm moving up one segment, 4, 5, 3, 4, 2, 3, etc. Okay, I would do the same thing, obviously, on the other side to assess side bending. And I'm going to grade it 0 to 6. 3 is normal mobility. 4 is a little bit hyper. 2 is hypo. Okay, I'm going to show you the scale and we'll talk about it. But that's how we grade it in our system because it gives us sort of a target for our treatment. Okay, last one we're going to do in this position is rotation. And that's going to be from cranial or above. So I'm going to just come here, resting on her ribs. She's relaxed, because this is always passive with mobility testing. And then I'm going to start up here in the lower thoracic spine. And I'm just using single finger for palpation, index finger. I'm not blocking. And I'm just rotating, and I'm feeling that cranial or superior spinous process rotate on the one below it. And then moving down a segment. So each time doing 3 or 4 little wiggles and moving down a segment. And this is the part where she didn't side bend as well, and she's just a little less mobile here. So, I'm going to give her a grade 2 for rotation to the left at her L1-2 segment. Okay. Now, is that pathology? No, not necessarily. Does it hurt? No, not necessarily, but it does tell us about her mobility. Okay. And this kind of testing takes a long time to learn how to do. It's very technical and it takes hours of practice, just like anything that you want to get good at. But it's incredibly valuable to have your fingers on the segment and be able to figure out what that tissue is doing. Is it overreactive? Is it stiffer? Is it looser? It doesn't have good research to back it up in terms of reliability. Don't get me wrong. If you and I both go through a lot of training and do this, there hasn't been a lot of studies that show that we can agree with each other. But within the same practitioner, you can be very consistent in terms of looking at different segments. And so for me, it's sort of like maybe has the least evidence, but I wouldn't trade it because it gives me so much information just through my hands in terms of the status of the spine. Okay, so that's mobility testing. We can do it in the SI joint. We can do it in any joint in the body, the TMJ, the phalanges, the AC joint. It's always part of our evaluation. And with a patient like this, it would be part of your evaluation, including the SI joint and the hips and everything in the neighborhood that could be contributing. Okay, we did the shear test already for the disc. So let's talk a little bit about our correlation in general. You would want to integrate any other information that you had. If you had any radiology to integrate, if you had any blood tests, anything else at this point we want to include. MRI, CAT scan, X-ray, anything at your disposal you would want to integrate. So let me pull up the slides. Let's see where we are. Hope you guys are doing all right. Okay. So we left off looking at this diagnostic pyramid. All right. So what have we ruled out with this examination? Right. We looked at the skin, and she was a little sensitive. That was about it. Subcutaneous, also a little thick, but nothing, no problems. Ligament fascia was okay. Muscle tendon was ruled out with our resisted testing. Joint capsule was part of the problem. It may not be causing the pain, but it's part of the problem. Bursa, not really an issue. Cartilage, she had a little bit of discomfort in side bending toward, so we can't really rule it out. No signs of joint entrapment, because that would be the case if there was zero mobility, which wasn't the situation. The nerve is fine, the disc seems fine, the bone seems fine. Vascular would be ruled out with other blood work. So what are we left with? Here's a little segmental mobility testing slide. Oh, and just to step back a second, I talked about the grading of joint mobility, and here's our scale where you can see again 3 is normal, with increased numbers is increased mobility, and we found a grade 2 of rotation to the left with Kara, and we found some muscle guardiness too. So again, so this is where she came in, right? She said it hurts here. And this slide is from the internet, and it's from this sijointfixation.com. And basically what they're teaching physicians, orthopedists, is if your patient points to this area, they have an SI joint problem. Okay, that's their level of clinical decision making. Actually, that's not everything. They also say that it's likely the SI joint, if they have pain with sitting, or if they have pain with sit to stand, or if they have pain with stairs, right? I mean, that is incredibly non-specific. Okay, so we can do better than that. If only it was that simple, that somebody could just point to their SI joint and you knew that was the problem. But as I mentioned, there's a pattern that fits with this patient that's really nowhere near the SI joint. Irritation of the superior clinial nerve and the medial clinial nerve, which is lower in the lumbar spine, reproduces pain right in this area. And you can see from L1 and L2 how this distribution of nerve can mimic pain in the SI joint. And there is a syndrome that fits this picture, thoracolumbar junction syndrome, or also known as Main syndrome. He was a French physician who did some amazing work, and later in his life he did some really interesting work looking at cervicogenic headache, showing that in the same type of presentation how findings in the neck can cause head pain. But he came up with the criteria where there was tenderness or skin changes at the iliac crest. Okay, check. Kara had that. Segmental dysfunction in the thoracolumbar junction, usually unilaterally. Check. Segmental dysfunction could be anything. It could be disc, facet, capsule, anything. But she had a mobility disturbance there. He had clear imaging, which we're not going to do with Kara because it's not indicated. And the last thing that he used in his criteria was relief of symptoms with a lidocaine injection, which we're also not going to do. But she is following this pattern. And it's just a good example of how you need to rule out all these tissues in order to really know where you're going with this. And this is just one of the many examples, right? Lateral elbow pain, same thing from the cervical spine. Shoulder pain from the cervical spine. Heel pain from the lumbar spine. All of these areas need to be ruled out. And the way you get good at this is learning how to do all the tests for all the parts of the body. More examples of other referral sources. Janet Travell and David Simons, they mapped out trigger points that all refer to this area. There's the gluteus medius, the piriformis, pain right in the multifidus in that area. The quadratus lumborum can refer to this area, and this is one that I commonly see with Main syndrome, is this letter D here, the longissimus thoracic. Up in that thoracolumbar junction, you can palpate and find a trigger point that will frequently reproduce their pain, and then you know you're onto something. So tissue diagnosis drives our clinical decision making. Without being able and having the skills to really do a thorough examination, you're going to be sort of guessing in terms of your treatment. And this is what the Ola Grimsby Institute has sort of embraced, is this need to take the long path of education to get really good at this stuff. And if you want to have a rewarding and successful practice, the more you put into this, the more you'll enjoy work. And you know, you spend enough time at work, if you're anything like me, is you might as well make it great and rewarding. All right, so that's a little bit about our concept in terms of thought process for clinical decision making. I'm going to stop this recording and we'll take a little break, and next time we get together we'll show some treatment techniques that apply to this. Thank you for your time, and I will see you soon.